from the American Academy of Pediatrics.
Welcome to this special episode of Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's focus this episode on important news in the world of immunizations.
So, Joanna, Mira is a kindergartner. How's she liking it?
I'm saving the details for our but I can say it's a huge change. She's going from the oldest in her preschool to the youngest in a big public school, but she'll always be my baby.
Oh, that is so sweet. You know, this is traditionally the time of year where families in Wilmington rush to the pediatrician to get forms signed and vaccines updated before the 30-day mark when kids can't come to school without them.
A busy time for pediatricians. But speaking of vaccines, there are some big products coming down the pike that will change routine vaccines across the country.
I think we have to talk with the newest member of our Five Timers Club, Dr. Sean O'Leary, chair of the AAP Committee on Infectious Diseases and a pediatric infectious disease and public health specialist at the University of Colorado. Sean, we are ready to get vaccinated with all the latest information. Welcome back.
Well, thank you. I did not know that I was now in a special club, so thank you.
So, yeah, we have a smoking jacket waiting for you and everything, but being a pediatrician, you're not allowed to smoke in it.
Not an issue.
Really, we have a tote bag waiting for you that says Pediatrics on Call. But one development my neonatology colleagues and I have been eagerly awaiting is the new monoclonal antibody to prevent RSV. It's called nirsevimab.
I've heard it pronounced various ways. Nirsevimab, yeah.
I know there's a lot still being worked out, but can you tell us about this product? Will it replace the antibodies we used to use for our NICU babies?
Short answer to that is yes. So let me just give you a brief overview of this new product. So this product, as you mentioned, is called nirsevimab. It is a monoclonal antibody product to protect infants from RSV. It received FDA approval in July and an ACIP recommendation in early August for all infants under 8 months of age during or entering RSV season, and approval for certain high-risk children entering their second RSV season. And we can talk about what those high-risk categories are, but they are essentially the same as what the AAP recommendations historically have been for the product we know as palivizumab. And we can talk more about the details around what are we going to do about those two products. In terms of how well does this product work, it looks to be really good. The safety reviews based on the clinical trials were very reassuring. It looks to be a very safe product. And from a biologic standpoint, we wouldn't really expect any surprises from this kind of a product. And then in terms of efficacy, it also looks to be very good. As a product to prevent a mucosal disease like RSV, we wouldn't expect it to be all that great at preventing infection. So kids can still get RSV infections with this. But what we want it to be effective at is preventing significant RSV disease. And it looks to be very good at that. Roughly about 80% protection against RSV-associated lower respiratory tract infection hospitalization. So 80% is a big number when you're talking about the leading cause of hospitalization in children under 5.
And the dose, is it similar to palivizumab?
So nirsevimab is a long-acting monoclonal antibody. So we're used to giving 5 doses of palivizumab for the high-risk infants. This product, actually, you only have to give it once for the healthy infants. And then in the second year of life, they get a single dose as well. And so the antibody lasts for at least 5 months, maybe longer. And so this is a one-time dose. Now, the dose is based on weight. And so pediatricians are going to have to pay attention to that. And it's also can be different in the second year of life as well. So there are some dosing changes. It does come, though, as a pre-filled syringe. So that's very nice. And they have different sizes for the pre-filled syringes depending on weight.
Sean, I imagine my hospitalist colleagues and me sitting around playing checkers and waiting for something to happen this next winter. Now that we know a little about nirsevimab, who's eligible to get it?
Right. So that's one of the things that I think is surprising to a lot of people right now is that this product is recommended for all infants. So the entire birth cohort essentially. So if you're born in the hospital, and these dates in terms of seasonality, we're working on really clarifying the guidance on that. There are a number of informational materials on the AAP website right now to kind of go into detail on this. But essentially, if you're born in what historically has been defined as the RSV season, October to March, the recommendation is to get the product in the hospital, similar to the way that infants should get the hepatitis B vaccine. Or if they don't get it in the hospital, get it shortly after birth in either the pediatrician's office or wherever else it may be available. And we can talk about some of those implementation issues, certainly in this first year. Just to be clear, that includes all the healthy infants as well as any of the infants who historically have been recommended for palivizumab. Entering the second season, so this is for those infants who are going to be 8 to 19 months of age, entering their second RSV season this fall. Those, again, mirror the AAP recommendations for second season prevention for palivizumab, with one very important addition. So the recommendations are for children with chronic lung disease who are still undergoing some kind of therapy. So, for example, oxygen. Children with severe cystic fibrosis, severely immunocompromised children. So these are some of the categories. And then the important addition to this is American Indian and Alaska Native children. And the reason for that addition with this product, which is a big addition compared to the older recs, the reason for the addition of that is there have been some recent studies showing that the risk of hospitalization for these infants is far higher than the average U.S. infant, 4 to 10 times higher than the average U.S. infant. And secondly, in a lot of jurisdictions in the U.S., a lot of these American Indian and Alaska Native children live so far from hospital care that they often require helicopter evacuation, et cetera, if they were to get sick with RSV. So that was the reasoning behind that additional recommendation. Now, a question that keeps coming up is, well, does that mean if you can't get this new product, nirsevimab, that those children are now eligible for palivizumab? And the answer to that is no.
But I hear this is an expensive product that will be given, maybe both in hospitals and in the ambulatory care setting. You mentioned talking about implementation. I mean, what does that look like for pediatricians who practice in various settings?
Yeah, so to be clear, what the company has released at this point is that it will be $495 for private stock and $395 for the VFC program, which purchases vaccines for roughly half of U.S. infants. And so, yeah, that's an expensive product. Now, when you add up some of the other routine childhood vaccines, for example, pneumococcal conjugate vaccine, you give at 2, 4, 6 months and then 12 to 15 months of age for healthy infants. That's 4 doses of that. That's actually more expensive than this one-time dose for healthy infants. But I don't want to sort of whitewash the fact that this is an expensive product. Now, on the other hand, it's a lot less expensive than palivizumab, which was typically over $1,000 a dose, 5 doses through an RSV season monthly. So much less expensive than the existing product for high-risk infants.
You mentioned the Vaccines for Children program, but not all providers and only about 10% of birthing hospitals participate in VFC. That means many children may have barriers to accessing nirsevimab. What needs to happen here?
You almost got the pronunciation right that time.
Yeah, we're going to
nirsevimab.
School me.
No, it's okay. So, this implementation this year is certainly going to be a challenge. I have no doubt about that. For hospitals that don't participate in the VFC program, the question is, are they going to stock the product? And we really don't know the answer to that. Most birthing hospitals do stock hepatitis B vaccine, even if they don't participate in the Vaccines for Children program. But that product is $13 to $15. And so they can absorb that cost into bundled payments. With this one, in the absence of an increase in the bundled payment from HHS, they may be stuck holding the bill. Now, there has been discussion that HHS will likely increase that bundled payment, but we really haven't seen the details on that at this point. Now, for the outpatient setting, that's a challenge. This is, when you're talking about the entire birth cohort for a given practice, that can add up to tens of thousands, if not hundreds of thousands of dollars of upfront cost, depending on the size of the practice. Now, the manufacturer has given some assurances regarding not invoicing for 150 days and being able to return expired product, things like that. But that doesn't mean that the bill isn't still going to come due. So recommendations from the Advisory Committee on Immunization Practices become official when the Morbidity and Mortality Weekly Report, otherwise known as MMWR, is published. Payers then have up to a year to be paying for the products that are represented in that publication. And so what that means for pediatricians is that they may purchase this product, give this product, and yet a payer could say, oh, sorry, not going to pay you. And that's a real problem. So AAP is working very hard to work with the payers across the U.S. to ensure that they will pay, sort of on time when the providers ask for payment for this, but no guarantees there. So that is certainly a challenge for these busy pediatricians who are operating in practices with really very thin margins.
So, Sean, there's a semantic point that I hope doesn't turn into a logistical point, which is we're calling this part of the Vaccines for Children program, but it's a monoclonal antibody product. Do we consider that a vaccine? They help protect against disease. They strengthen immunity. What do we call it?
Yeah, that's a great and very important question. So as a monoclonal antibody product to prevent a disease, we can consider this a passive immunization as opposed to the other vaccines that we give, which are generally considered active immunizations, where we give the product and it induces an immune response, and then we're protected from the disease down the road. This is basically giving us that protection in a more direct fashion. Functionally, I don't know that most parents are really going to care. Some parents will certainly have questions and want to understand exactly how it works. But for all intents and purposes, it's doing essentially the same thing. We give this as a shot to a child to prevent disease. And that's the same, so from the perspective of the average parent, that's the same as the other vaccines we're given. Just works in a little bit different manner. Now, getting back to the nomenclature, so within the Vaccines for Children program regulations, as well as the Affordable Care Act, which has an impact on this as well, there's actually no explicit definition of vaccine. And so it was legally determined that because both of them essentially say that preventive care is covered, this is considered preventive care. And so it's being included in the Vaccines for Children program and also considered by ACIP and therefore covered by the Affordable Care Act with no copay as a preventive measure to prevent disease. Now, the FDA classified this product as a drug or a therapeutic and not a vaccine. And what that has led to is a number of issues around coding, which also may impact billing. And so there are a lot of things there's a lot of work going on right now to try and fix that, if you will, because right now, immunization information systems, otherwise known as immunization registries, are set to deal with vaccine codes, not drug codes. Similarly, most electronic health records or EHRs, their forecasting systems for vaccines are set up to deal with vaccine codes, not drug codes. And so AAP has been working with AMA to try and get the coding switched to really more of a vaccine code. That could also end up impacting billing. So, for example, where I am in Colorado, our state Medicaid program has said we're simply going to give an administration fee for this product that's the same as the other vaccines that are in the Vaccines for Children program. But that may not be uniform. That was a decision made here where I am in Colorado. But other states may make other determinations, and payers similarly may not follow suit. And so payers will negotiate with practices or with health systems. What are they going to pay for an administration fee for vaccines? And that administration fee incorporates counseling and storage and handling and things like that. And that may be different for this product. And so, again, AAP is working hard to try and get that more uniform, similar to other vaccine products.
Is the AAP also working on talking points for families? I ask you this, Sean, because you're a communications expert when it comes to talking about vaccines and their efficacy and safety. So how are you going to be explaining this when families come to talk to you about it?
Sure. Yeah. And absolutely, yes, AAP is working to develop those things. I mean, it is a new product, and that's always a challenge. There's always a delay in uptake for any kind of a new product, whether it's a vaccine or something else. And in this case, really, it's the first new It's the first new immunization that we've had in the routine childhood schedule in over 15 years, really, since rotavirus. And so we've got a shared clinical decision-making vaccine and serogroup B meningococcal vaccine for older adolescents. And we've got some adolescent vaccines, but those are all roughly Tdap, meningococcal conjugate vaccine, and HPV vaccine have all been around for over 15 years. So here we have this essentially the first new big thing, right? And how do we talk about that? So, I think we could talk for hours about how do you communicate about vaccines. I tend to fall back on using things like motivational interviewing, using a strong recommendation. You can also use, this hasn't been as well studied, but using your own personal recommendation, saying, I got this for my child, or I would get this for my child. Motivational interviewing is just a nice framework because I think it really builds a good communication with a parent and allows really for any types of questions they might ask to be answered in a more of a collaborative manner than kind of a bossy or preachy manner. The other thing I think that is an advantage of motivational interviewing is it's really it can cross cultures and races and ethnicities in terms of it's not targeting one specific type of person and who you're communicating with. You're really working to build an effective dialogue with really any individual.
Speaking of new products, there is also an RSV vaccine for pregnant women, which could be helpful in preventing RSV in infancy for up to 6 months. What's the science behind this evolving vaccine? I'm around 5 months pregnant myself. Should I be getting it in the fall? And if mom gets this vaccine, does her baby still need any monoclonal antibodies?
So the FDA just approved a new maternal vaccine, and it appears to have similar efficacy for protection against lower respiratory tract disease related to RSV in infants to this nirsevimab, the monoclonal antibody product we're talking about. And you could think of it as working in very similar fashions, really. They're both passive immunization for the protection of the infant. ACIP discussed this at length in the June meeting before either product was authorized and looked at cost effectiveness models saying should we be giving both of these products to a given pregnancy/infant? And the short answer to that is really probably not. The incremental gain you would get from one on top of the other is really, really small. And so for most healthy infants, the recommendation will be likely get one or the other, but not both. Now, that presents some really challenging issues, right? Does it incentivize obstetricians not to bother stocking this new vaccine? Does it incentivize hospitals to say, well, I think the obstetrician should have done this, so I'm not going to stock the infant product? So there's those types of issues. And then the other issues that I think that are going to be more common is if for the individual taking care of the child in the hospital, how do they know if the pregnant person got this product? Now, they may know off the top of their head. There may be a record of it, but most maternal vaccination or maternal immunizations don't end up in registries. And so you're really relying on the documentation in the obstetrical record, which may or may not be complete. And certainly with a new product, often those take a while to get incorporated in there. So a real challenge. We don't expect there's any harm from getting both. So that's not really the issue. It's probably not worth it. Now, there likely will be certain children who we would recommend both. So, for example, if somebody got the maternal vaccine and then delivered the next day, that's not really enough time to get any kind of meaningful immune response to pass on to the child. So that child should get nirsevimab. Premature infants, I think we would probably also say should get nirsevimab because most of the maternal antibodies are transferred in the last trimester. So there are going to be exceptions where some infants would have the benefit of both products, but for the most part, it'll just be one or the other.
Aside from RSV, COVID-19 seems to be here to stay. This summer, we've seen a recent resurgence in COVID cases and admissions, and the virus is continuing to evolve. So how do we protect kids as they head back to school?
Right. So COVID is a real challenge right now. One, we already know that there's relatively low vaccine uptake among kids, particularly under 12. So that's been a challenge. And that's multifactorial. That's both hesitancy and refusal, as well as a lot of the implementation issues that we've seen throughout the pandemic of, a lot of providers not stocking the product due to various challenges with stocking and administration. So what do you do right now? And right now, honestly, so we're going to be there should be a monovalent, so meaning a vaccine that targets the most recent circulating strains of the Omicron variant. So that was XBB that this monovalent product was designed to protect against. And then we have this new variant that's starting to emerge, EG5, which is very, very similar to XBB. And most of the vaccinologists and immunologists say that this XBB monovalent vaccine should provide great protection against this emerging other Omicron subvariant. But what do we do today? Right? Because that product is probably going to be available at the end of September. And so what I've been telling folks is if your child is high risk, so with some kind of a severe immunocompromising condition, certain other medical conditions, those children should stay up to date regardless. And then once the new product is available and they've gone a few months past their last either infection or dose, go ahead and get the new product. Similar for younger infants. So children under 2 among children are at the highest risk of hospitalization. And actually, the hospitalization rate of kids under 2 is not that different from the hospitalization rate of those over 65, which we know are all pretty high risk. So I think those kids under 2 should get their primary series as recommended with the currently available products. But things are going to change pretty quickly here. And the other thing that I should mention that has been a recommendation that kind of may have glossed past a lot of people is right now for kids, depending on which product you had, 5 and over, 6 and over, now they're just recommended for 1 dose no matter what their vaccination history is. And that's a bit of a change in recent months because it's been recognized that just about the entire population in the US has some immunity to COVID at this point, be it from prior vaccination or infection or both. We know infection does offer some protection from severe disease from COVID, but we also know that vaccination on top of that offers additional protection. Even this far into this pandemic, we are still wanting more data and we're still following the data very closely in terms of how to make these recommendations. One of the things that we really need to understand better is this whole issue of long COVID. In some studies, 16% or more of kids developed symptoms distal from their COVID infection that persisted for months and months and months. That's a huge number, given that 90+% of kids have already had COVID. If 16% of them are getting symptoms months and months later, that's a huge public health problem. And we also know that vaccination does offer some protection against long COVID. So that's another thing that we really need a bit more data on in terms of what is, given the current epidemiology, the current seroprevalence with these 2nd and 3rd and 4th infections, how at risk are kids for long COVID. The prior numbers that we have are based on, earlier data. And so we want to have a better understanding essentially of how big of a problem is long COVID going to continue to be, and really in everyone, but in children, of course, as well. And that's going to also help inform our vaccination recommendations as well. Certainly we've been mostly focused on prevention of severe disease, hospitalization, and death. And that, of course, is really important. But long COVID is a really big problem as well.
I feel like we could keep talking about COVID, but we wanted to inject another infectious disease. If you remember our last podcast with you, it was episode 150 in March 2023 for listeners who are interested. We spoke about the evolution of the pneumococcal vaccines from PCV7 all the way to the development of PCV20, which back in March was still being reviewed by the CDC. Is it now available for kids? Is it better than PCV15, or would either one be acceptable for most kids?
Yeah, well, more is always better. So, no, I'm kidding. So the recommendation from ACIP and AAP is that PCV20 can be used as an option for pneumococcal conjugate vaccination in children, either PCV15 or PCV20 for healthy children at 2, 4, 6, and 12 to 15 months of age. Now, I was joking about more being better, but, there is 5 additional serotypes compared to PCV15. Why didn't they just make a preferential recommendation? And I think there are a number of reasons. One is we have good immunogenicity data on the 2 products, but we really don't have good effectiveness data in the real world. And how that immunogenicity data is going to play out, we don't really know. And it is good to have multiple products for the same disease in case of shortages, that kind of thing. The one major difference, I think, between the 2 products that we need to pay attention to right now is for high-risk children. And so high-risk children are, historically for pneumococcal conjugate vaccine. I won't go through all of them, but there's a list that's on the immunization schedule every year, both from CDC and AAP. And it's been a relatively limited number of children who need I'll call it the polysaccharide vaccine, PPSV 23. So that's the 23 valent that's been used for decades in older adults. It is recommended for certain high-risk children. A couple examples: asplenic children, children with cochlear implants, immunocompromised. Anyway, there's a list. The big change with the new recommendation is the addition of moderate to severe asthma to that list. And for a lot of pediatric practices, that's a, reasonably sized proportion of their patient population. And so the recommendation for these higher risk children is that if they got PCV 13, so the old version, or PCV 15, and they still need additional protection because of their high risk condition, they can get either PCV 20 or PPSV 23. If they got PCV 20, they're done, right? And so it presents a stocking issue for pediatricians. They could stock one product for both their healthy children and their high-risk children versus 2 if they use the PCV 15. So that's really the major difference.
That is going to be huge. And as much as you've shared with us today, Sean, we've got to talk about one more vaccine because flu is coming. And I remember last year I got my COVID and flu shots together. Should I plan on doing that every year starting this fall? Will there be a combination shot so that I only have to wear like one Band-Aid?
Yeah, great question. So combinations are in development. You won't have any for this season. I think flu vaccination is, it's important every year. It saves thousands of lives every year in the U.S. Even with the modest vaccination coverage we get of 50 to 60% in the U.S., that's still saving thousands and thousands of lives. So very important to continue to vaccinate for influenza. And that's really actually what I've been stressing lately is COVID, we have this new monovalent vaccine coming. You might want to wait on that one. Flu, no, get it when it's available. What we're hearing from the Southern Hemisphere, particularly Australia, is that this has been a pretty bad flu year down there. And that often predicts what we're going to see here. So we may have a rough flu year, making vaccination all the more important.
Sean, we have covered so much. Is there anything you want to add? One last takeaway for our listeners?
I've been getting so many questions about vaccine hesitancy and, the fact that a lot of parents refuse COVID vaccine. Is that really spilled over? And I think the message I'd like to give pediatricians is that the data aren't really suggesting that we're having a major slippage in vaccine confidence in the U.S. Most kids are still getting their vaccines. Certainly there are going to be a share who now are refusing vaccines as a result of COVID, but that's not really what the data are showing. So I would say, keep recommending vaccines in the same way you have. Don't go into these visits expecting to be refused, because when you do that, you present uncertainty, and that really can make parents uncomfortable about getting vaccines. So continue to strongly recommend vaccines and expect success.
Dr. Sean O'Leary, why do I get the feeling we'll have you back for a 6th time, especially as we see more of what's going on with RSV? Thank you so much for joining us today.
All right. Well, always nice talking with the both of you.
To learn about the latest vaccine developments, join us at aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
I am just so happy right now. You'll remember from a previous Say Ah that our youngest has just started college. And I'm not talking to him as much as I did when he lived here, but he has called to say that he is loving, absolutely loving his school. He feels completely at home there. He's found his people, and he's going to start taking climbing lessons, I guess like at one of those indoor gyms. And so, he's just doing new stuff.
That sounds like so much fun. And my say is that Mira's going to kindergarten. So it's the first time that I've had to do the kind of quote back to school, even though it's like first time in school stuff.
Oh, yeah.
And I'm really enjoying it. It's so much fun, like buying all the supplies, getting to meet her teacher, other people in the class. It's like really cool to be having a kid who's like in kindergarten now. So more to come on that. I'm sure I'll have a lot of kindergarten moments to share.
Oh, yeah, I bet. That's a year's worth of say-ahs right there. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll have the September edition of First Up.
We'll also talk about the AAP's equity agenda with our new Chief Health Equity Officer, Dr. Joseph Wright. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.